Welcome to the Simplified Dentistry podcast. Join us as we discuss clinical, operational, and financial aspects of your practice, help you enjoy life, and dare to simplify dentistry.
Welcome back to the Simplified Dentistry podcast. I'm Dr. Mustafa Shakan, along with my co-host, Dr. Mortaza Shakan and Dr. Richard Offit. We want to welcome today's guest, Dr. Muhammad Ali Shazib. Dr. Shazib is the Dean and Chief Clinical Officer of the Workman School of Dental Medicine at High Point University. He received his DMD from Boston University and his residency in oral medicine at Harvard University. Welcome, Dr. Ali Shazib. We're glad to have you with us today. Workman School of Dental Medicine is a new institution that is embracing a shift in dental education. How about let's start with where you generally see dental education today?
That's a great question and a pleasure to be here on this forum and podcast with you all. Dental education right now is at an interesting period. The rate of technology advancement is unprecedented. There is a very strong momentum for convergence between medicine and dentistry and healthcare as a whole. And the economics and governance and policies of our healthcare system is also in a fairly flux state, if you will. So dental education really has a lot of these challenges to face right now. And where it's heading is the need for integration, adaptability, emotional intelligence, and entrepreneurial skills, which we believe will help position our learners, our graduates, for the evolving changes of the future.
Dr. Shazib, let me kind of set the table a little with this. A student, he wants to become a dentist. Why High Point University Workman School?
I think the answer is every school does its best to graduate the best leader in dental healthcare. But if they're specifically looking to be in an environment that is highly experiential, which means the real world guides our education, the real world guides how you practice, how you learn, how you develop relationships, HPU Workman School of Dental Medicine is in my opinion, the premier, destination or choice for those students. If you're someone who's looking to learn about mergers and acquisitions and how that happens, well, we're doing them. Our learners get a chance to do them with us. If they're interested in material science and they'd like to spend time learning about, non-invasive, self-assembling peptide materials like Bavardis, we have clinical trials that we conduct that they can be part of and conduct and be part of. If they're interested in advocacy, we have partnerships lined up where they can go in and be in part of advocacy. And clinically, through our distributed model, which is the first of its kind in the country, every practice we have is out in the community, owned and operated by High Point University Health, which is a non-for-profit organization that provides care for all patients from fee-for-service to Medicaid to special needs to peds to adults, which mimic the authentic environment of a group practice, private practice, DSO, hospital, FQHC. So we've got all that lined up where to the care curriculum, which I've summarized as clinician, advocate, research, entrepreneur, our students get a reality TV lens approach towards our evolving field.
Piggybacking on what Dr. Offit said, what exactly are you looking for in an applicant? Who's the target for you guys?
So our values alignment. So our values and our core values are collaboration, compassion, integrity, innovation, and growth mindset. And I would say we look for those values through the unorthodox admissions process that we have developed. We're one of the very few programs, one or two programs out of all the other schools that are not on the centralized app, because we have developed an application process that is looking for those values to be quantified and qualitatively expressed. Some are reflection questions, some are third-party tests that are more of psychometric tests to look at situational awareness. And then we have a series of interviews that are OSCE-style interviews. And then we have a simulation haptics psychomotor test that is a surprise test that our learners take, where we're not looking at how perfect their depth perception is, but how they are able to respond to an exercise that was thrown at them out of the blue, and they have to pick up a handpiece on the simulator and do this cutting a tooth in air that looks like an airplane simulator cockpit, right?
So
So
when you talk about psychomotor skills, one thing that we always saw is you don't always have great hands when you come into dental school, but they can teach you to have great hands. You can have good hands, and they can teach you how to have great hands. Are you kind of ruling people out who walk in and don't have good hands?
on the contrary, that's a great question. I totally agree with what you're saying. There's science to support from the Surgeon General's office in Netherlands. They did a very large multi-center study looking at laparoscopic surgery skills and learning curves. And they came up with this through haptics simulation research that everybody can reach mastery. Almost everybody can reach mastery, but the curve to reach mastery may vary depending on individual characteristics. So we believe everybody can be trained to be excellent in psychomotor skills, unless there is a medical condition that may, prevent that from occurring. So on the contrary, we're not looking at measuring psychomotor accuracy. It's more so, how do you respond to failure when you're given an exercise that may be completely out of the blue? Because in healthcare, a lot of the times we are dealing with non-textbook situations where we have to make a judgment call that is not black or white. How do you navigate those blurry areas where you need to make an improvised decision with the best available information?
A few years ago, well, actually, let me correct that. Many years ago, I was on a panel where we spent a couple of days discussing who makes the best, what type of person makes the best doctor. And it was on the panel were psychologists, there were behavioral scientists, there were physicians, there were dentists. That was me. And we discussed this. And what I think was most stunning with what you just said was the alignment of values. Whereas so many times it has been, what'd you get in biochemistry? That's not good enough.
Yeah.
Okay. So maybe talk a little bit about that when you're admissions. I mean, the alignment of values. I think that's so important to young people, especially that are seeking a career in healthcare.
I can't echo and stress the importance of what you just stated. I think we're also in our admissions process that has received a lot of interest is we don't require the dental admissions test. It's not to say we're not looking for academic resilience and scholastic aptitude. The average GPA of our entering class was 3.4, and the incoming class that's going to enter currently, and we haven't obviously closed our cycle yet, is above 3.4. To us, that GPA is not a measure that is a direct relationship to how likely they will succeed as a healthcare provider, because the measures we're looking for are qualitative, which is empathy, compassion, communication, humility, collaboration, teamwork. And I think if you look at the most successful clinicians out there who patients love and rave about and get excellent care, are usually the ones who have that and technical skill rather than technical skill and not that. And we believe both are important, but we think 60% is values and the life skills, if you will, and 40% is the knowledge of biomedical sciences, behavioral sciences, clinical sciences that make you a knowledgeable, well-rounded clinician. And I think the ratios traditionally have always been favoring 80% scholastic and 20% of the others. And I'm just throwing very arbitrary example, but I think that's a trend we're trying to be more cognizant of is what are employers saying the most about the graduates they're taking in? What are their top 10 concerns? And if you cross-sectionally review most of our employers' feedback about dental graduates, they wish they had better understanding of time management, multitasking, communicating with team members, talking to patients in an empathetic way. How do you conflict management of a grievance? Or how do you deal with a HIPAA breach? Who would you talk to? What would happen?
We've had several guests on who have said the biggest thing missing is actually learning how to do the dentistry. So they're saying, from when we went to school to now, you're cutting less teeth, you're doing different things. How are you guys approaching both of those things? I mean, how do you accomplish teaching the dentistry and then teaching this?
All within 4 years.
Yeah, spot on. So my job talk when I joined Hypo University, from when I joined initially as chief dental officer, was called the 3 hour conundrum. And the 3 hour conundrum was that why does it take 3 hours, or why are we told 3 hours is the time that we have to cut this crown in the sim lab? Because if you look at that, that does not at all link with the reality of how much time it takes to do a crown prep in a viable manner that will sustain the business of dentistry. And if you compare the best simulation programs out there, that's aviation. They have the best training standards for simulation for commercial pilots and military pilots, Air Force pilots. It's the rigor of how complex and real life is simulation based on the real world. We have invested heavily in areas where we can teach and train our students based on benchmarks of the real world. So they will not pass if they're not able to do a specific procedure in the simulation room or simulation lab better than the real world. So if in the real world, the average 2392 takes you, a two surface posterior restoration takes you, let's say, an hour, just throwing it out there. You have to exceed and beat that in the simulation environment to be deemed as competent or to have a pass in that sort of exercise. Not just the procedure, the whole encounter, the whole visit, from seeing the patient, reviewing medical history, consenting, local anesthesia, isolation, all the steps that are laid out. So our goal is to mimic real world practice, bring it into the simulation lab, into the lectures, and so that our students never see the 3 hour conundrum. They don't. Maybe they're taught 3 hours that you need to do X number of procedures in 3 hours to be deemed clinically competent. So our whole cycle in our preclinical education is very, very rigorous. Our first years, as we speak, are in preclinical boot camps where they're having to shoe a cusp or do a restorative procedure with the element of time. Time is such an important factor that our students don't get a review of the time they take to do a procedure. And last but not least, they get to replay the recordings of their work. So we can actually show them an action replay of their work so that the clinician or the faculty is not perceived as someone who's going to intimidate them or scare them by giving them a subjective opinion, but they can actually sit with the learner and watch the video and sort of coach together.
So there's a benchtop camera that is recording their procedures.
So we have.
Do they get to throw a red flag and appeal a decision? You know, I mean, if they don't like the way it's going, can they throw the red flag and challenge it?
Yeah.
That'd be great competition. We should bring that up.
Yeah. You get one flag, one flag per procedure. Yeah,
that's right. So funny, like a VAR referee. But
exactly.
It's the goal is to be to gamify learning in a way that has impact to patient care or the benefit of our patients, but also to be safe for our patients. If we can demonstrate competency at a higher bar level in the preclinical environment, and it doesn't mimic the real world, then what's going to happen is our patients will not get that quality of care that they need when our students go in that environment. And then it leads to instances where when I was in dental school, and I think every dental school does a phenomenal job, and I have all the respect in the world for them, but it took me 6 times to impress on the same patient to get my impression perfect. Sure. And I can only feel that if I were that patient, how many times have I manipulated the mouth and the tissue and probably created some injury or distress to basically get learning accomplished. That was learning through what you would say
trial and error.
Yeah. No, after 6 times, you've kind of done your crown lengthening.
Yeah.
And it becomes easier. Yeah.
So we think that's not the balance. We believe there are 4 elements of a successful organization, and our 4 metrics are elevated patient experience. So making sure that even if it's education, the patient experience has to be the number 1 goal, because the student needs to see a modeled patient care behavior, a model patient care encounter. So that's elevated patient experience. Number 2 is improved healthcare outcomes. How fast can we get somebody in with pain? A say yes mentality. Let's get this person in their pain. Let's eradicate disease and stabilize. Step 3 is team wellness and well-being and culture. How is the leadership focus of the team? How is the culture of your team? Dentistry has intimate relationships, the hygienist relationship, the assistant relationship, the care coordinators, manager, other dentists, community, societies. How do you manage those relationships? And 4 is fiscal sustainability. It should not be a sin to talk about fiscal sustainability if you're a school. You should teach your learners how each practice needs to run to be sustainable, break even, or beyond, so that the overhead cognizance is there.
You mentioned one thing earlier. Your practice model is community-based practices. I think that's where the clinical experience is versus the traditional floors of a dental school where you go to the operative floor to the restorative floor, whatever it is. You also mentioned acquisition. So do you guys acquire practices that goes into your network and that's where the students learn, or do you start practices, or do you do both?
A great question. This is the part that gives me a lot of excitement is a clinical network. It's called HPU Health, which is a non-for-profit clinical enterprise of the Workman School of Dental Medicine. Myself and Dr. Kevin Kane, who's a senior associate dean, he's a MBA and PhD in strategy. So he studied the dental industry and trends for over 2 decades. But we do both. So we acquire practices. So these are dentists that have a philosophical synergy or compatibility with our model, and they've got a good reputation, and their practice has a necessary footprint that meets our needs. And what we would do is go into a negotiation to acquire and purchase their practice. And that would result in the dentist and the staff all becoming full-time employees at High Point University. And then they get calibrated as faculty and staff. And they enjoy all the benefits that, any other employee would enjoy. And then if they're a landlord, we would have a lease agreement. And if, and the goodwill of the practice, we would purchase, including the equipment. And then we would, over a period of 90 days, do our due diligence. And then we would bring them onto our electronic health record, which is Epic, which is fully medically integrated. And then we would start to do the standardization journey and process. And the parallel, we're also building brand new practices, de novos. They're typically large 30 operatory surgical specialty hubs that will be for specialty care, for example, special needs dentistry, anesthesiology, sedation, perio-pros cases, and ortho, and peds, which will have its own dedicated wing. So we have these big, large de novo surgical specialty hubs, one in Greensboro, a major city, one in High Point, a city, and one in Winston-Salem, a major city. And around each of these 3 hubs, we will have about 10 community practices through acquisitions primarily, and some of them may be through de novos that we build, but about 70% are going to be around acquisitions to reach a total of 275 operatories. That is what we need for 60 students over 4 years, about 240 students, and EGD residents. So that's how we calculate our growth in the community. But we have, to your point, what is radically different is we have 0 student clinics or bays. So our campus building is all simulation, digital dentistry lab, 3D printing, ExoCAD, future practice, which is like a dental practice that looks like the practice with 2030, and all the haptics labs that we have. That's our campus and classrooms and learning.
So there's no dental faculty practice within the confines of the Workman School of Dentistry. That's out, if you have faculty, they're out in those clinics.
And all of it is faculty practice. So all of it is faculty practice. The way our faculty is compensated is like a faculty practice compensation. So everywhere they are the site director, and them and the manager together ensure they're aligned with the HPU philosophy of care and all the other operating protocols.
So if I'm a student and I'm getting to where it's time to start treating patients, you're going to put me in one of these acquired practices, and what happens?
Yep. So you've already gone through that for a year or 2 because you're spending half a day a week in these practices, learning all the support care roles, running the morning huddles and all that stuff, and looking at the scheduling. So by the time our students are in their 2nd year, they've learned how to administer local anesthesia. They've been credentialed with Epic and CPR and all the necessary didactics about history and exam and all that stuff. They've likely done that at some capacity as an assistant in the practice. So the goal will be then a group of students, no more than 1 faculty for every 3 students. So in traditional dental school models, you have a bay of maybe 8 or 10 operatories and 1 faculty. In our sort of model, the goal is intimate learning environment, so that you're in 1 practice, maybe 8 operatories, and you have 1 dentist, the attending, the clinician, the site director, and then you have a D4, a D3 that are sort of running 1 chair each, and an AGD resident. And the AGD resident is a graduate, dentist who's learning more complex scope of dentistry. So there's no more than 3 to 4 learners under the direct supervision of a faculty. The faculty is responsible ultimately for the classification and assignment of the patients to the people that are under the supervision of the learners that are under the supervision of the dentist. So if I was the supervisor and had 3 students with me, based on their skill set levels, I would assign my schedule to them, but I would be responsible for the delivery of care at the quality of the care that is committed by the site director.
So I'm a 5-year grad of the Workman School of Dentistry, 5 years out. Rick's a 5th-year grad out of another school. How are we different?
So the hope is that the Workman School of Dental Medicine grad is not a cookie cutter grad. We hope that they're cross-pollinated across the CARE domains. I hope that, I don't know, 40% are C, and then the other 10-15% distributed equally are ARE, so that we have a very broad pollination of thought leaders and movers and shakers. I think these are the most risk, tolerant, or have a high appetite for risk students we have in our class. Like
they take smart risks.
Yeah.
They took risks, right? And I think, who likes risks? And most of the people who love risks are entrepreneurs, or they're people who are looking to not fit in that cookie cutter model, if you will. So I think likely from the 1-year alumni comparison between our grads and other grads, our grads will have a lot more real life exposure. They would have done a lot more clinical experience, management experience. They would have been able to develop the confidence of networking and connecting with movers and shakers in our field through our various connections in our board of advisors. The commitment of our board of advisors, which includes CEOs of companies like SprintRay, Revere Partners, which is a private equity fund for oral health, from lots of other leaders across DSOs, robotics, and material sciences. The goal is that our learners have enough exposure to be able to thrive in whatever environment they want to go into, and not go back and say, oh, I wish, they taught us digital dentistry more, because now every practice I've interviewed at, they require proficiency in using an iTero scan. Well,
it's almost going to be the flip side. Your graduate's going to come out with these views of how practice should be, and then they're going to go out there into a lot of dental practices and go, oh man, I'm riding a dinosaur here.
Yeah.
And so it's going to be real interesting, I think, to see how the culture works, and it'll be exciting, right?
Yeah.
I mean, to see where your kids are going and what they're doing, and they'll have to express tolerance for many of the other dentists out there, guys and gals who don't have the technology background that they have.
But at the same time, I think you're also going to see there's a overwhelming void for docs who have entrepreneurial experience. Dr. Offit and I ran different things in the dental space, and so we have had our hands in other things. You just don't see that. You don't see docs who understand, the business acumen. You're seeing well-accomplished doctors now going to MBA programs to get that experience. But now, if you can put that in your curriculum, you can train graduates to come out with that, understand entrepreneurial things, understand the business side. You're revolutionizing the profession, in my opinion.
Yeah. Oh, yeah.
And doing it still in that 4-year model too.
We like to ask guys, what mistake did you make early in your career that you learned from? And what piece of advice would you give docs from that mistake in your learning experience?
I think the mistake that I often think about in my journey through life, and not necessarily in this role that I'm in right now, is having an important realization of emotional intelligence. And I think a lot of times in our life, we are chasing after a goal that is numerical or quantitative. It could be a grade, it could be a salary, it could be a gold medal, or whatever accolade it is. I think I was late to understand the importance of emotional intelligence, which is really having the ability to understand human emotions and interactions and the effects of those that can happen when you're dealing with people in teams. And I think if I would say this to anybody that is in healthcare or any sort of aspect in life where you deal with people, is those people that are extremely successful from those that are successful. What separates the two is the astute understanding and mastery of emotional intelligence. And, that includes how you listen verbally and non-verbally. That includes body language. That includes talking slowly and listening. And I think all those things create immense impact and success. And I think if you have emotional intelligence and EQ, and you've got a strong passion and dream that you don't ever negotiate for, that combination makes any goal in life become true. The unrealistic thing might be time, but it may not be the achievement of it. And that's something that I truly believe in my life. If I had, I guess, emphasized more on EQ than scholastic results or material achievement, I think understanding of that would help a lot of other people.
That's phenomenal.
Dental education has gotten extraordinarily out of reach for a lot of people just because of the sheer burden of the cost. With the model that you have with HPU Health, and its ability for those practices to basically be self-sustaining, has it been able to modify the financial burden on your students as a result of that? Because it's more of a self-sustained clinic versus the model that the three of us came through, probably you came through, where without state subsidy, the model doesn't work. So can you address that?
Yes, and I love the question. And Dr. Kevin and I have a bet on this, is the way we have structured our financial model is that the tuition fee of the student, like most schools, the tuition of the student supports the clinical enterprise, meaning the practices are not able to carry their own overhead and they need to be supplemented through the the fee going higher, or state supplement or grants or other revenue that are outside of patient care. Our model is dependent on each practice being its cost center or profit center, if you will, meaning being self-sustainable. And then that way, our hypothesis is by the time our students graduate, because we just have our first year class in right now, and they're not yet, producing in practice and generating clinical revenue as they learn and gain their education. Our hypothesis is that we hope that the 4 years of tuition that they're paying for, ultimately through clinical productivity and the clinical enterprise being self-sustainable, allows us to reduce the overall burden of tuition, or somehow get them a credit for their work that would reduce tuition through the success of the clinical enterprise, so that the burden of debt is not always increasing, but we find a way where we can actually find a break to the increase in tuition that happens almost everywhere every year. Or what other schools may do is increase enrollment. Okay, let's increase to 80 students, let's increase to 100 students.
Yeah.
So our hope is that the clinical enterprise and the clinical education, through its reality TV lens and through its self-sustainable, fiscal sustainable model, is going to relieve the burden of the financial obligations for pursuing dental education. And we hope that will demonstrate the ability for it to be 3 years of tuition and 1 year of clinical practice. Like that would be the ultimate wow,
So is it appropriate to say that the student is kind of paying into it and there is a possible credit to what they've paid? So let's say I paid $100,000 and we figure out that it's this era of profitability. You're going to credit that student $20,000 at some point in time?
It'd be a lovely thought. It'd be a lovely thought. Yeah. It's obviously not official. It's not obviously a model we have put out there. But I would just say the idea behind it is, if they're ethical, professional, seeking education, and they're productive, how can we make productivity count in a way that it decreases debt? And yes, whatever avenue allows us to achieve that, we want it to be a contribution towards reduction of debt and not the trends we see right now, which is
how about this? When HPU Health has you said it's going to have 270 operatories to support a class of 60 thereabouts. And what's interesting to me is going to be the culture that you have to have. You have to have the same culture in each of those. You said we're going to have 10 or 12 practices around Winston-Salem or 10 in Greensboro, whatever. So you almost have to have a vice president of culture, that's going to make sure that the culture in each clinic,
You have to have the same philosophy and
yeah,
culture.
yeah, exactly,
Yeah.
exactly, is compatible. Now, where are you going with that? I found it hard enough when I practiced across 3 or 4 offices to have the same culture in 3 or 4 offices. Talk to us a little bit about that.
I mean, it seems like we're having a conversation here in our sort of drawing room, figuring out strategies for these situations because they're such important topics: culture, community, connectivity. I think they're all the 3 C's that have a feedback loop with each other. Because if you don't have enough culture, you don't have culture if you don't have community connectivity and communication platforms that everybody is working on to. So sometimes the information lag or lack thereof is it erodes culture. And then the other aspect is being very intentional about a bi-directional, multi-directional relationship with your entire community, because we have micro communities all across, if you will, the mothership, which would be the campus. So how do you bring enough campus into each practice, and how do you bring all the practice environments into into our main campus? And it's not an easy task. I think having a chief wellness officer is something some organizations have done. A change management champion who connects with each culture champion from each practice has been demonstrated. I think the chief dental officer and the director of clinical operations set the operational language or the operating system, but the operating system is only that as successful as a cultural system you put in place, because there needs to be a why that everybody can resonate to, and there needs to be that passion for the experience we're providing that will bring alignment for culture. So we have a couple of things that we have done to address that. One is everybody has a rigorous onboarding experience. When I say rigorous, it means they see the HPU experience, they see the wisdom experience, and then they see the practice experience. And then continuously, every 3 to 6 months, there are touch points that are built on activities, healthy competitions of doing good, values reminders. So every week, there's a recognition of one of our values. Okay, who's done something very compassionate or collaborative or of a high integrity. So we're trying to recognize champions from our teams. And then anybody who is in our team in management or director level or has any responsibility of personnel oversight, we develop their leadership skills internally and externally through partnerships with the Bell Leadership Institute, where we send a lot of our faculty and staff for leadership
Sounds
training.
like you've talked to Dr. Workman before.
And that's where, Chick-fil-A sends its leadership teams there. A lot of the healthcare systems do. Heartland Dental does. Majority of the dental school deans go there. ADIA has a partnership. So those are some areas of leadership development that we focus on. And then the other part is having a performance evaluation system that's not just once a year annual performance review, and then it creates this surprise. The goal is to have active, frequent touch points that are informal check-ins every 2 to 4 weeks. And I think there was a Harvard Business Review talking about 11 days or 14 days being
for the feedback,
Marcus
loop.
Cunningham wrote this piece,
to
right,
complete
about
the loop.
right. So the goal is active loop, so it's never something that was a shock to the employee, and being able to have bi-directional feedback. So being able to understand what's the sentiment of employee engagement, because I think that's the most important element or factor or variable to look at is employee engagement. How many employees are going to say that I would recommend this place to my friends and family, either for the healthcare or for employability, right? That's the biggest compliment you could receive, is your own team members hopefully raving about where they work and referring their friends and family.
Well, let me do one follow-up question. When you do a de novo, you control the culture from the get-go. When you're acquiring practices, and so let's say you visit these 2 doctors to my left here, and you decide that that one of them wants to sell their practice. You're interested in it. How do you evaluate the existing doctor and for the cultural fit, or do you just assume that you have to teach your culture to them? Is it because your culture is innovative for dentistry, and there's not going to be many 40 to 50-year-old docs out there that automatically have a similar culture in their practices? So I'm just curious, how do you go about presenting to a doctor that you're going to acquire his practice about the cultural requirements, if you will, of being part of HPU Health?
Spot on. Again, a phenomenal question. The answer is not easy. We've had to say no respectfully more than we've had to proceed forward. And a lot of it does go, most of it's been because of cultural or philosophical differences. And we have to set a fairly fine filter of what we think is the aperture has to be really fine for defining what cultural compatibility is. I think there's a lot of culture that the practices will bring into our ecosystem, and we have to be accepting of that. We also have to accept the values of the existing practice, but then we have to be very bold, upfront, and intentional about our culture, our values, our way of doing things upfront. And I think, if I learn from our mistakes or learning lessons, I think we were not bold about that in some examples.
It comes down to saying, this is who I am.
And this is who we are. And I think we were a bit shy of doing that because we were just toeing new into this sort of area of going and seeing what's the interest of being part of HPU Health. Now, after learning through the feedback we've received through our acquisitions, the importance is being very clear and honest and transparent about the why and how we're going to do it, and then let that simmer and be processed by the interested party, and then following up and having a frank discussion. I think when we don't have those discussions openly and we don't discuss the difficult things like exit clauses, contingencies, and we sort of skirt around that, then the element of trust becomes questionable, and then that can disrupt the culture. And I think the basic framework of culture is trust, and then being able to take it from there. And if you said what you're going to do and you're doing it, or if you're not, you're explaining why, then people will follow you. And if not, then obviously what happens is sometimes with acquisitions, the culture and compatibility can lead to turnover, attrition, and the other things that happen.
Thank you.
So I would kind of say, what our organization is, Simplified Dentistry. Essentially what we're doing is we're trying to allow docs to go from good to great. We're trying to get, what we would characterize as seasoned but aspirational docs, to advance their careers. It seems like your grads and your students are in this aspirational population who is going to have a lot of skills to be able to apply it. We'd love to have your guys kind of participating in this as much as possible. If they want to sign up for us, we'd love to have them.
Thank you.
My question,
if we can help them.
I mean, I hope we can provide.
Maybe they can help us.
They can help us, but we can provide.
I think, Dean, that maybe your students can help us.
But we can provide input and help answer. These guys are aspirational. They're looking at different things. Now we can also be a resource in the community. Your student can ask us a question and get an answer, and then he can take it back to you guys, and we can collaborate in there. I think that would be a great thing. But the question I ask everybody, or we ask everybody at the end of our podcast, is with Simplified Dentistry, what advice would you give the population to make dentistry a little simpler, just to simplify the thing? I know you talked about emotional health and things like that, but what would you say?
I think it's alignment on vision and ensuring that you have systems in place that are not people dependent, but process dependent, and that you have developed the ability to measure progress through ways that your team can see as well, so that dentistry becomes fun, it becomes more predictable, but it also is able to deliver those amazing experiences that I think most of us get excited about, is when you can give somebody a smile and they may have been dealing with a very difficult phase in their life, and we were out there to help them and regain confidence and trust in society. And I think that's the important part to make dentistry simplified, is alignment to vision, alignment to values of who we are, and developing systems that make that why consistent, and very much effective.
Yeah. Well,
That's
thank you very
great.
much for your time. We appreciate it. I think what you guys are doing at High Point is fantastic.
Likewise.
I think it's revolutionary, and we look forward to kind of following this and hopefully being a little more involved with you guys.
Our invitation is is officially always open for you guys to come visit and spend time with us and our students and our faculty. So happy to touch base and figure out a time for you guys to spend time with our students. We've got 1 or 2 podcasters in our class.
Oh wow!
Oh wow!
Social media influencers. So I think they love these opportunities when they can do a bit of a reality TV lens show or Q&A session. So would love to have you on our forum and have you do a Q&A with our students in a live sort of direct Q&A session, and you can have it on your podcast or we can do it both ways. But I think I'm saying whatever I'm saying. To believe what I'm saying, why don't you meet with our students right now? And there's 6 months of being in our program. Just have a live Q&A with them, and they'll give you.
That'd be so fun.
That'd be fun.
That'd be more fun than work for sure.
right.
Right?
Be afraid of what you ask for.
Yeah, well, no, because
That's our culture.
It lets you think back to when you were making decisions and say, was I that alive or not?
Yeah,
right.
exactly.
Was I that spot on or not? Anyway, I appreciate your comments
and give you that
time
other
with us.
perspective too.
Yeah.
Thank you very much. We appreciate it.
Yeah. Thank you.
Absolutely. Thank you so much.